in the dustbin which is in the bin which is kept for the gowns only. And the shoes, they should be again left properly. So we shouldn't have these kind of chaos when we eat. Thank you, Sajid.
Thank you, everyone. In this 2 days entire course, this is probably the only lecture which is lecture and no demonstration, and she is the only person who can do it probably. So this is always given to her. Henceforth, all next things are actually will be doing it. So there will be less talk and more of doing it. So I invite next speaker and demonstration by Dr. Sushma Sharma, Professor of GY. She will be taking you for the clothing and gowning.
Thank you. At the outset, let me thank the organizers, Department of Surgery, under the leadership of Dr. Sachin. So we learned about the basic.
You are on YouTube also, live.
All right. This is not audible. If you don't know me, I am Dr. Sushma Sharma. I am professor in the Department of OBGY. So I'll take you through how to scrub. Once you've entered all the etiquettes that Vaishali ma'am told you, you need to actually ready yourself for the surgery which involves scrubbing, gloving and gowning. So these will be our learning objectives. So you should be able to carry out a correct surgical scrubbing, which here in our local terminology we say washing. So wash up when someone says. You should be able to wear the gown and the glove correctly. Not only that, you should be able to de-glove and doff the gown also correctly. Right? So the initial surgical hand wash, basically you need to sterilize the area of the hand, the forearm as well part of the arm, right? And you should be doing that using appropriate scrub solutions. So this we speak from years of experience. We feel that no, I should get my hand wash which is very nice for my skin. No, that is not allowed. So it should be standard. Its purpose is to remove, we all know that there are microorganisms all over the skin surface, so remove them. And not just to remove them, the scrub solution which is chosen should be such that it should be effective against a wide spectrum. Not only should it be effective, it should have a persistent effect. At the same time, it should not be damaging the skin. So ideally, you should have a first wash and then a second wash. We'll go through that. Right? So look at the initial scrub technique. It involves, even if you're wearing the cap mask already when you enter, once again before you're readying yourself for the procedure, make sure that it is secure. Sometimes during the surgery your hair just falls out, right? Or your mask suddenly falls down, or if you have glasses it starts fogging. So check all that. Now here we don't have hot water, but most of the places there is hot and cold water. To make sure you check the temperature, you don't scald yourself. Or if you're in a very cold environment, again, you don't keep shivering through the most of the surgery. Then carry out a social hand wash or a rinse. Then wet your arms above elbow. Again, there's a common mistake. Then apply the scrub solution. Now, how much of it? They say 5 ml. Now, difficult to understand 5 ml. So, around the size of a circle which fits in your palm should be enough to correspond to 5 ml. If available, use the nail brush. If not, it's all right. Then rinse up to the elbow, then apply more lotion, the scrub lotion up to the elbow, and then once again concentrate on the hands up to the wrist region and then rinse fully. So studies have shown that. Now if you will focus on the yellow areas, these are the commonly missed ones, right, which remain
unsterile, right? They're full of organisms. So if you see on the back of the hand, can you see the yellow ones? And this is the palmar surface, followed by the green area, and we only end up cleaning what is shown in white, which is really not up to the mark, right? So the hand washing technique, I think all of us got very familiar with these 6 steps during the COVID. Even if, I don't know, where were you all in school? Even if we were in school, we all got very familiar with this 6 steps of just hand wash, right? So I guess it must be in your memory. This is very important, but it is not enough. All right. So subsequent wash should be up to the elbow. So we'll watch a small video to the same extent. So if you see, this is taken from our own country, from one of the premier institutes. So first they have applied it till the elbows, and see the direction of the flow of water, never towards your hands, always away from the hands and dripping from the elbow, right? Not ulta, right? Sometimes when you're a beginner, it is difficult. Again, make sure that you allow all the water to drain. People go like that, flooding the floor, and then someone slips. You're not supposed to shake the hand to do that. If facilities are there, please use a towel each for each hand, right? Again, the direction of wiping is from the hand to the wrist, not ulta. Okay, so use a separate one. If you don't have, you may skip this, right? You may directly go on. So you'll wonder what we are showing and what we do are slightly different. Well, as per the local facilities available is how we manage things, right? Now once you have scrubbed, the next thing would be to wear the gown as well as the glove. Primarily, you must be absolutely knowing your glove size. The glove should not be such that there is space left between your finger and the glove material. You'll not be able to handle tissue effectively. At the same time, it should not be so tight that you don't have easy movements. You'll end up cramping your hand, right? So you should choose, so you get hand fatigue. If you want, you can wear a size smaller and see. This goes into cramps like this, your fingers, right? We've gone through all that, so we're able to tell you this with our own experience, right? Ideally, one could be using the powder-free gloves. They are ideal so that there is no deposit on any surface. But well, countries like ours, we still can't afford that for every patient. So we use it for people who are at high risk. Then, if you are having any medical condition yourself with respect to the skin or any allergies or dermatitis, then there are latex free gloves also available if you have latex allergy. So identify these things early on in your career, right? Don't end up having terrible lesions. I had a senior, who had horrible lesions, then ended up having scars and all that. So identify it if you have a problem. At the same time, don't be unnecessarily fussy and prescribe these things to the poor patient. All right? So now we'll have a quick look on how to wear the gown and the glove. Right? So again, this is the same setup. So identify the neck area of the gown. It should be a autoclave sterile one. And this is typical in our country where there's no one else to help you. I'll show you an ideal one also. So you are quite on your own. So you do not touch the gown anywhere. Identify the armholes and just slide your arms inside. And then you have already kept your set of gloves. Now look at the gloving, very important. At no time are you touching the outer surface. So left hand glove goes in. Now you have little liberty because that is already gloved. So the gown area should go inside. So you can tent that rubber band type thing on the thumb and then tuck in the wrist area of the cloth. See? So you tent the thumb and then fold it. So don't just crumple that and make a laddu over here. It becomes very painful after some time if you do that. So this is how you are now gloved and ready, and hopefully someone will tie this poor fellow's gown, right? So this is where there is manpower crunch. So you can identify with this kind of a situation, isn't it? Especially the bacha log, junior most, especially if there's an emergency, everybody has rushed in and you are left there alone. So still you can follow this and enter the OT, and I'm sure your anesthesia, another bacha or another intern, or hopefully by then the patient is on table, maybe the OT helper will be ready and he or she will tie your thing, right? Now let's look at the ideal one. You must know this because many of you may venture out of this country, and I don't want a single student of this institute to go anywhere on this globe and feel lost and feel that, oh my God, this is something I don't know. So this is the official training video from the NHS, right? So check the cap, mask, although she was already wearing it. Now here is what we will do. So here you have a pre-packed set for yourself. Can you see that? It's ETO'd. So you open this without touching the inside. Okay. And this is a set of gloves of your size which you have kept ready to be handed over. Right? And first do the hand wash. Social hand wash. This is the nail brush which she is opening and keeping ready. Okay. And then rinse yourself till the elbow. Now if the sleeves are too long, see the direction of water flow. If the sleeves are long for you, most of us wear scrubs a little bigger than what is our fit, isn't it, for comfort. Just roll it up. You should not have scrub sleeves like this, reaching close to the elbow joint. So 5 ml of the scrub taken, and see now first time she is just, but look at this. Yeah, so next time be alert. There's no hurry. It's not adequate. For the next surgeries, you know, if you have multiple cases, you can maybe take a little less time. So the first wash should last 2 minutes. Have you ever paused for that much time? Introspect at every stage where we are doing things as per norms and where maybe we are a little short and we could correct ourselves. Alright? So the first wash, if you see, those are the 6 steps all of us are familiar with, which we learnt. See the neglected areas being taken care of, and it ends with the wrist. And then she will go in a rotational movement, not rubbing, right? Okay, so that is ideal. Then this is the first rinse. Alright, then takes the nail brush, takes same amount of scrub onto this. And now it's not recommended to scrub the rest of your skin. If you read older literature, it causes more skin damage. And do this only for the first case. Do not keep doing this for every case. Otherwise, you'll end up causing damage, and that will cause more harm than good. So this is the nail brush discarded, and then you rinse yourself right back up to the elbows. And then comes the final wash. So do you see how elaborate actually surgical scrubbing should be? Alright. So very, very focused on the way the water is dripping down. No compromise on that. And then to shut the tap also, please use your elbow. And now look at this. This we will all do. So watch this video very carefully. So open this, the sealed one. Make sure don't touch the inside of it. Identify the neck region. Okay, they have got separate paper towels for each hand. So the hand is being wiped. Again, patted dry, because paper, if you are very agitated in rubbing it, it will leave residue. And one for the other hand. We don't have this luxury, but if you go to such a setup, please know what you're supposed to do with those 2 pieces of hand towel, right? One for each hand, and then comes the gown. So identify the neck region and Move away such that the gown will not touch any surface. Let it drop down. Don't shake it. Right? Identify the armholes. Slide your arms inside. And just go. Do not take, in the ideal way, do not take your fingers out. Your fingers still remain inside the cuff. So try practicing that with the set which is provided for you. So see, like, we do sometimes, no, or we used to in our childhood become rabbits or something with us, full sleeve sweaters and all. So you keep it like that. Now watch carefully the difference in the gloving. So what she has done is she has turned it upside down. So the right one goes to the left and the left one has come to the right. Right? So you cross your hands, pick it up, flip it, then it matches. Right? And with the cuff there, so no time is the skin exposed, right? Then you slide your glove inside. Now this went off. Okay. So now this kind of sterile gloves has got what is known as a card, right? So you hand over only the card part and you don't take it off, and then you turn yourself at 360 degrees. You hold that tassel. You do not hand over the tassel. Someone just pulls out the card, right? And so you have the liberty of tying it yourself, right, to the front of the gown. And now you're ready. And like Vaishali madam said, this is where you should keep your hands above the waist level. Do not fold, do not rest it somewhere, do not put it in the armpits. Okay? Right. So now how do you remove the contaminated gloves at the end of the surgery? Very important. Suppose you had something which you don't want and the surgery still continued. See, so you tent it. We saw this step before. Tent it on your thumb and then take it off. So you are, with the under gloves, you're not touching the outer surface of the operating glove set. And then you pack them together, discard them, and then put on a new pair of gloves, right? So safely discarded the gloves, and then you can continue with the surgery. All right. Now, everything is done, the procedure is done. Now you need to discard both the gloves. So we just saw that, as well as the gown. So ideally, you should keep your inner pair on and then take off the gown. Your assistant can remove the top knot at the neck region. See, and then you fold the gown on itself. So this contaminated surface is all wrapped inside, and you still have a pair of gloves on you. So you didn't touch any contaminated surface either. So this is the correct way of doffing, right? So not only is donning important, degloving and doffing is also important. And of course, choose the correct bin in which you are supposed to place that. So familiarize yourself with that, right? So you might have seen, so if you'll soon have your resident as teachers. Has it done for you? No. So you learn, this is the model of skill learning actually. So from novice we become an expert. So please focus. I've made a big red circle. So if you look at your teachers, your professors, you think they're not doing the appropriate things. It's not so. From a novice, when we become an expert, there are some shortcuts. Imagine, what example should I give you? Everybody drives? Okay, let's go even further back in life. Everybody wrote in the red line, blue line book? Yes? After a stage, were you exactly following the loops and the crossing and the dots? So we took some shortcuts, right? Does it mean you were writing wrong English? No. So this may happen. This is the model of skill acquisition, where from a novice you become an expert, and then you may notice a few things. Don't focus on those points. Focus on where you are in this ladder and do the things accordingly, right? So now we will actually take out your sets. Everybody has one? So do select your appropriate glove size. If you don't have, please make do with the one provided to you. Right? You'll wear kya?
When you drop your gloves and gown, keep it ready with glue only so that you use that.
Yes. True. So do not put it in any bin. You're supposed to use the same set of gown and gloves when you'll go and perform the wet lab activities. Right.
So open your glove packet and keep it ready, alright? Like this. Like this. Keep it on the table. In front of you. Now once you have opened the gown, please go and identify the next side. Did you get it? The next side. And then just let it drop down. Even after dropping, you may be having the closed end towards you. Turn it such that you have the open end towards you. Everybody is on the same step? Right. Now, just identify the arm opening and slide your arms inside. Now you decide you want to do the NHS way, then keep your fingers still inside the cuff. Or you may just pull it gently out without holding it with fingers. Can you manage that? The other side, what will you do? Alright. So now so partners can help each other. Please tie your partner's tassels. Okay. Now comes the gloving part. Right? Let's follow the easier one. So keep the gloves open. At no point will you touch the surface which is used for operating. So pick up the glove. So this is the inside. Okay? This is the inside. Should I stand up on something? Go such that first thing to learn is to know which is right and which is left. It's written on it. The next thing is to identify where is the hole for the thumb. Yes? And hold this rubber band like thing and then just pull it. Pull it as much as possible for the first one. Alright? Now pick up the second one. Same thing. Now you have little liberty since this is glove. So you can tent this on your thumb, fold the wrist area and then slide the tented part of the glove onto the folded wrist area. Now do the same thing here. Tent it. This is not cloth, so you don't need to fold it, but in the actual cloth gown you will really need to. So see, when I touch this surface, it's always with another glove, never with bare skin. Okay, and then ensure that fingertips are absolutely snug. So adjust the gown now. You have freedom to adjust it. So now you will realize whether you have the correct size of glove or not. Yes? No. Many people have a bigger size, a smaller size. If anyone wants to learn the other method, let's learn that. Or let's learn doffing first. Right? Now I need to change this set of gloves. So what should I do? Does anyone remember from the video? What do? You tent it onto the thumb. Tent it onto the thumb. Right? And now you will not touch the outside. It's the reverse now. Do not touch the contaminated side. So you do this and hold the inside, and no one does this. You should have one glove fitting into the other, and then you discard it. So at no point am I touching the used surface of the glove. Right? And now would you like to try the other method? NHS method of gloving?
Yes.
Try. You may not practice, but it's okay. So if you saw, we have a little non-ideal situation. We do not have a dedicated gloving and gowning area in our OT. It's not ideal to go and gown yourself and glove yourself on the instrument trolley, right? But for obvious reasons, we don't have that. So if you go to another facility after this training, don't feel lost. Don't feel lost. Okay? So that area ideally should be the dedicated one. So fold it like it is in a new pack and then try the NHS method or try it at leisure. It's your wish. So इसमें उल्टा करना है. The right comes to the left comes on the right. We'll watch you then. Hopefully they have not tied it very well. So now when you doff your scrubs also, the gown, please do it with good method, right? Don't just yank it off.
And just keep everything with you. You will require that for the next bit.
So who's trying the NHS method of wearing the glove? May I have a show
Show of hands. So we can supervise what you are doing. Yes. That table. Are you trying the NHS method? Yes. So right for left and left for right. Have you placed it correctly? Yes. Yeah, right. So now use this hand. No, use this hand to pick it up. Place it. Place it. Place it over there. Where's the thumb? Yeah, there's the thumb. So pick it such that you place it here. Right? And then you flip it. So you use the rubber band. Yes, and then you flip it. Got it? Yes. Did everyone watch this? No. So watch again. She's now become a boss. Chalo. Now pick this up from the left hand. Place it over your right palm. Yes. Hold the rubber band. Use your finger. Yes, and then it just gets flipped. Right? That worked. Everybody on this table learned? Yes, everyone on this table learned? What do you want to do? No. They have to be facing you. The fingers have to be facing you. Which is right, which is left? तो उल्टा करना चाहिए. हाँ. Everybody on this table watch now. Teachers can help one table each. This table is done. There are some 3 tables left. Now pick this up with your left hand. Place it on the right palm. Hold the rubber band area. Wear it. वो बहुत अंदर है तेरा हाथ, इतना अंदर नहीं रखने का, यहाँ तक. It should be almost at the tip. So you know your fingertip should be almost at the edge of that. Yeah, and then it gets flipped. Okay, तेरी गड़बड़ के लिए. Yeah, you have to rotate. You manage, right? Yes. So is it clear which table is left to learn the NHS method? All no. All okay. So place your, can I just have this? So place your gloves right on the left side, left on the right side with the finger end facing you. Right? Okay. Now hold the right glove with your left hand. Place it on the right palm. Pick it up. ऐसा नहीं रे, कितनी ठंड है यहाँ पे, 20 degrees. Pick it up, my dear. Place it, look, watch her please. Place it like this on the palm. Now hold the rubber band area and wear it. It gets flipped. So it gets flipped. Yes, got it. Everybody got it. Yes. With the second hand, do the same thing. Place it this way. Yeah. Hold the rubber band area and wear the glove. It will get flipped. Yeah. So it gets flipped. Okay. So you have liberty now little bit because you already gloved. So you can hold this area also. Thumb thoda sa rotate ho gaya hai. Same thing. No, but you have to do the same thing. So place it again on the palm. अरे इस हाथ से पकड़ना, हाँ, और पहनो.
With our next session, and that is on suturing and knotting. नाही मी येतो तिकडे पण. So I'll be very brief in suturing knotting lecture because we have to do so much hands-on for suturing and knotting. Believe me or not, this is one of the most important activity, and please try to learn something which is perfect, right? So dear friends, if we go to the brief history of wound closures, it dates back to 10th century BC, when Sushruta, the great surgeon from India, who used to take ants and apply it to the edges of the cut wound. The ants were held over the wound until they seized the edge of the wound, and then they were decapitated. So using that mandibular grip as one of the staples for the surgery. So present day staplers which we use, they are nothing but a kind of modification to 10th century BC. There were also techniques of using thorns. They were put into the wound edges, and around that silk thread used to be tied so that to bring the wound edges together. So everybody right from that age knew that if the wound edges are brought together, they heal pretty fast, thus leaving a smaller area to heal. So the scar used to be better. Modern day suture material came from catgut. This is sterilized sheep intestine, submucosa, which was taken and sterilized and used as a catgut, which is even presently available. Can I know why it is called catgut? It is not from the cat. It is from the sheep's gut. Why it is called catgut? Anyone? Yeah, so it was a cattle gut. So initially it was a cattle gut, and slowly we always take shortcuts. So instead of cattle it became cat. So it's a cattle gut which was used, and this also came from a very interesting part, that this actually was used for the string instruments, and that was cord gut they used to call it, and somebody realized it has a strength, so why not use it for suturing, and then that was eyed through an eyed needle, and then that was used. So this is how the journey of catgut has started. Now we hardly use catgut anymore because we have better suture materials available. So by the end of this session, I wish all of you know how to apply core principles of suturing. What is best, what has to be done, and what should not be done. We need to see what are different suture materials available. We have every suture material with us. Tie a secure knot. Now what are the different knots that we'll see, and we are going to perform hands-on a two-handed technique and a single-handed technique. I'll also tell you why you need to learn both the techniques very well, both-handed technique as well as a single-handed technique. So principles of good suturing are, it should be an atraumatic handling. So your handling with the forceps, with the suture material should not be such that you are actually traumatizing the wound edge. It has to be gently pulling the edge, going through the suture with the suture material and tying a proper knot. Second is wound eversion. Remember, a flat or an inverted edge will give you a flattened scar or a depressed scar. What you always need to see is that the wound edges are everted when you tie the knot. So the everted wound edges give a better scar afterwards. Third is tension free. So when you tie a knot, it should be snugly fitting, just enough to approximate the wound edges. It should not strangulate the tissue. The moment the tissue is strangulated, you will have a bad scar as well as tissue necrosis. So cutting through of the suture materials. Even bites and spacing. See, if you see a nice painting where everything is symmetrical, you feel better, right? Same is the scar. So whenever you give any incision to any patient, it's going to leave a scar, and the patient will remember always
the scar, whenever he looks at that scar, he'll remember you. So as a surgeon, you have probably an immortal life, because even after you, the patients will always remember by the scar you have given. So you need to have a better scar, and that comes with even spacing, that is 1 centimeter away from the edge, 1 centimeter from the proximal suture. But it's not the way that it has to be always 1 centimeter. Suppose you are taking sutures on the face. The moment you take a smaller suture size, like 30, 40, 50, 1 centimeter becomes too long for that suture material to hold. So the moment you go for a smaller suture material, the spacing also goes on reducing. Approximately, thumb rule is 1. Suppose you go from 10 to 20, 1 millimeter size comes towards the skin edge, right? So if you are 50, the distance between two sutures would be 5 mm and not 1 centimeter. Is that correct? Suture materials, all of you know suture materials. Absorbables, non-absorbable. What is absorbable? The suture material probably is either worked upon by the tissue fluid and is broken down and is no more seen after few years. Unabsorbables are those which are inert materials, probably live longer than the life, even after your death the suture material will be there in the corpus. So those are non-absorbable suture materials. And then there are monofilament and braided. So monofilament, they are a single strand, usually synthetic materials. They are better because they are inert. Braided, they are braided, so naturally there would be gap in between the braids which can harbor tissue infections. So braided material is not very good when it is used for skin closure or something, because it would leave a bad scar either. And then there is something called as a pseudo braided. What is that? It's actually a braided material, but there is a coating on that which converts that into a monofilament. Then by origin we always say natural or synthetic, right? So why I am going slight faster is because I wish to continue with suturing, which is more important, knotting and all. So by origin we call natural collagen, linen, silk material. Synthetic are polypropylene, polyester, polyamide, PGA, all materials almost. And then metallic, stainless steel wires. So where metallic is used? Stainless steel. Anyone? Sternotomy closure in open heart surgery probably is the commonest. In general surgery, one important hernia repair, Scholdi's technique. So Scholdi's clinic uses only and only a steel wire to close all the fasciae in 3 different layers with double breasting. So this is about a stainless steel. By structure we have already spoken about this. Let us come to the needles. This is also one of the most important aspect. Previously, if you see the upper picture, there used to be an eye of the needle through which the suture material used to be passed, and that used to give a slightly bigger amount of tissue injury when it passes through the tissue, because a double strand of the suture material along with that needle hole would be passed. Now whatever you get is a switched on needle. Switched on is the end of the needle is hollow in which the suture material is packed and it is crushed on that. So it gives almost the same kind of diameter of the needle as well as the thread. Reduces the tissue injury when it passes through the tissues. So almost all the needles which you are using are switched on. Hardly ever we see now an eyed needle. Then there is something called as shaft and shape of the needle. You all are aware that there are straight needles, curved needles. So in curved needles there are so many different curves. It is called 5/8 of the circle, which becomes very circular kind of thing, whereas 1/8 circle, which is a flat needle. Now why do you need all this? Is consider you are suturing a skin or superficial part. where you might go away with 1/8 of a circle, which is easy to handle. But consider you are working in a depth inside the pelvic cavity. It would not be very possible that in a small cavity you are going with a flat needle and just going and turning it around. Vis-a-vis, you have a very small needle which has 5/8 of a circle, so you can just pass it, and in the small area also you can just pass through the suture and come out. So these are various ways in which the suture shapes of the needles are available. Now, point and cross section: round bodied, conventional cutting, reverse cutting, and taper cut. Now we all know, I don't have chalk and board, but then a reverse cutting is where the cutting area is inside and the flat triangle is the cutting area is outside, flat area is inside. Now this is used commonly for the skin suturing. Now consider, if the cutting area is inside, once you pass, the shape of the where can I show you? The shape would be like this. No, okay. So this is the sharp end, this is the flat end of the needle. This is conventional cutting. So if you cut like this, my skin edge is here and the sharp end is towards the cut end. So what can happen? The needle might go and cut the area, and next my thread is going to lie in this niche. Whereas when I am using a reverse cutting one, this cut area is away and flat area is bringing the skin together. Got it? So this is reverse cutting and conventional cutting. Round body is usually used for all soft tissue closures. Size of the needle, size of the suture material as well. You all are aware that from 0 to positivity is a thick suture material. As you go on adding zeros, it becomes thinner. Now why do you want to have different suture materials like this? Because we suture different organs in the body or parts of the body. Like for skin you usually use 2-0, but for ophthalmic purpose 2-0 would be a very thick kind of suture material, right? So what you need is 10-0, 11-0. So the moment you reduce on size, you reduce on the amount of suture material which is left inside that organ as well. So it is not that thicker the material, better is the suturing. It is about a proper sized suture material for a proper sized or proper tissue which you are going to handle. So depending on, you can use a thicker or a thinner one. Please do not have this in mind, especially gynae. Sushma is gone, okay, I am happy. So a larger or a thicker suture material gives a better grip. It has to be an appropriate suture material. So even 2-0 gives adequate holding of the sutures which are taken inside the body. It should not be 1-1-0 or something like that. So this is about suture materials. Let us come to today's activity now. All of you know there are different parts or different ways knots are tied. Right from fisherman's knot to so many different knots are being tied. You do that, what is that? काय करतात हाताने? Knitting of crochet and all. So there are various knots which are practiced. But in surgery we practice something called as a square knot, which is a basic knot and everybody has to know this knot. Now what a basic or square knot consists of is a simple knot. Simple knot is where a loop is created and the tail ends go apart or away from each other. That is a simple knot. And the same knot is again reversed on that, giving a square. So this is one of the basic surgical knots which is secure and which has to be tied. Now the only problem is it can get converted into a granny knot. What is a granny's knot? Where in a simple knot the second knot is also tied in the same way. So two simple knots in the same direction gives a granny knot. whereas two simple knots thrown in a exactly opposite side, reverse, gives you a square knot. Right? Granny knot is tend to sleep and is not a proper knot, is not a surgical knot. So try doing granny knot and correct yourself with a square knot in this session only. Then something called as a surgeon's knot, or this knot takes 2 throws. We'll practice that also. So for making a simple first knot, we get 2 throws, so it adds to friction, so it does not slip. So this is used whenever you feel that you want more security, because the surface or area which you are going to approximate can go away from each other. So wherever there is tension, use a surgeon's knot. Usually all hemostatic sutures always use a surgeon's knot because it tends to sleep less. Is that clear? So we are going to try all these knots. Before that, why knot matters? Secure knot, all of you know. It can cause bleeding because the knot slips off, superficial wound dehiscence, facial dehiscence, and the ultimate complication of that is an incisional hernia, which you do not want to see. Then we'll go on to that. We'll start with a two-handed technique of knot suturing. I'll show you and you will follow me with all that. So let us start the activity first. Now I have shown you the pictures. Just remember, two-handed technique is nothing but your both hands are available and you are just suturing it. Right? Now, just काय झालं? Remember one thing. So whenever you are tying a knot, first thing you require is to form a loop. Right? First thing is you need to form a loop, something like this. This is a loop. Is it? What you need is one tail end.
Clear? There are two tail ends now. So one of the tail end has to go through the loop. This forms what I always call as a simple knot. Is it correct? Okay. Now the ends reverse. Again another loop is formed. The tail end has gone in. Right? And can you see? It is exactly the reverse of the first knot. Just look at this. The white thread has come from right to left. Exactly opposite the purple thread. Is it correct? So when I tie this knot, this gives me a square knot. Got it? So this is a square knot. Now, why do you want to have one-handed knot and two-handed knots? So I will give you a scenario. We are taking a suture and trying to fix the drain. Right? So you have got a small thread which is passed. Both the ends are available to you. You are working on surface. So it becomes very simple to use both the hands. Right? So it's very easy. Both the hands. Even
not looking at this, what I'm doing, I'm making a loop, I'm passing, I'm making a simple knot. The second one and a square knot. Is it correct? Now consider this thread is long enough, very long, almost double than this. Will it be possible for me to tie with two hands? So long threads, it becomes very cumbersome, right? That is where you want a single-handed technique, where one hand doesn't move, your only fingers of the opposite hand work. Can you see? My hand is just holding the thread, a long thread in my hand. Only one hand is working and tying a secure knot. Correct? This would happen in cases of suture tying in a depth. Suppose you are working in pelvic floor or inside the pelvis. It's deep. There you can't put your both hands and tie a two-handed knot, right? So there you need to master your single-handed technique. That the thread and one hand is out of the abdomen, only one hand is making the knot, right? Now that is where your single-handed technique would come into place. Another thing is, normally we always do with a a needle suture. So on one side there is needle. So with this needle on, you can't do with a two-handed technique because there is a chance that this needle might injure your hand. So the needle part is in your hand and the other hand is making a knot. Is that clear? So there are various scenarios where you need to know a two-handed technique as well as a single-handed technique. So you will master double-handed technique and single-handed technique in this video. हे माझं हे दाखवा.
हे नाही, हे कॅमेरा आहे ना सरांचं जेव्हा करायला
नाही आधी माझं हे दाखव, ते पण रन झालं
हे तुम्ही कराल ना सर तेव्हा कॅमेरा समोर नसू दे, तुमचे हात दिसतील. आता काय होतंय, तुमच्या हाताशी येतात, खाली नॉट येते, दिसत नाही.
मग मी असं उभं राहू का?
एक तर तुम्ही असे उभे राहा किंवा कॅमेरा इथनं तर दिसतंय का बघा, तुम्ही इथं द्या, असं कॅमेरा राहते असं.
आता दिसतंय का? आता दिसतंय का?
ठीक आहे, असं नाही त्यांचा हात नको. ठीक आहे.
Okay, let us start with two-handed technique first. You have been provided with this. This acts as the skin incision, right? Consider this is the needle and you have hold it. So it goes
हात दिसत नाही मला, तेच हवं आहे.
like this.
Okay. एकच मिनिट.
Now you have got the thread which has come from the wound edges. Okay?
खाली
मला पीपीटी दाखव.
खालच्या बेस. हां बस
एकाच वेळी पीपीटी आणि हे दोन्ही दाखवणार नाही.
हाफ ऑफ स्क्रीन करणं.
ठीक आहे, सध्या पीपीटी तर दाखव, त्यांना सुरू करता येईल.
स्क्रीन दिसतोय का? पण ऑप्शन नाही आता. थोडं इकडे घेता
ओके.
HSJ 36LZ
थोडं खाली
36F.
घालू शकतो.
Okay.
थोडं तुम्ही असं
So you can see the first one. Hold it like this. Okay. Bring the away thread. This is away thread. This is towards you thread. Bring it towards your thumb. Can you see? Now what is happening is, the moment it is closed, you are forming a loop. I told you need to form a loop. Right? So loop is formed. Now pinch and bring it through the loop. So what I have done is, I have closed my index finger and thumb, right? And I have come out of the loop. right? I am feeding the thread, away thread, and I am coming back.
सर
Again.
सर तुमचं दिसलं पाहिजे ते नको
ते
आम्हाला.
नको आम्हाला कारण कळत नाही आम्हाला.
Okay. So now can you see a loop is formed? Now I am pinching my fingers, index finger and thumb, and through the loop I have come out. So this is pronation and supination, that's it. I have come out, now I am opening and I am feeding the thread. Right? Now I am coming back to my same position. I have come back to my position and you will see a simple knot is being tied. Got it? Everybody do it. Do it first. Okay, I'll tell you. In your left hand, keep the away thread. This is away thread which is brought towards you. Keep it in your left hand. Extend your index finger. Right? Your thumb is extended as well. Now your near thread comes on to your thumb. Right? Close the pinch and go through it. Just pronate.
सर माझी
Right?
माहिती सर.
Now I am feeding the thread. I am taking it away. Now I am again supinating. Right? Got everyone?
सर माहिती झाला युट्यूबला दाखवलं आहे तुमचा.
Okay. The team was there. So what I said was the away thread comes in your left hand. Extend your index finger. Put the towards thread on your thumb. Okay, close the grip. Come out through the. I'll come towards every. See, this is away thread, this is towards you thread. Away thread comes on your left hand. Extend your index finger. Keep this on your thumb. Right? Now see, the loop is formed. The loop is formed. Now what I am supposed to do, I have to take this tail end through this. How I am doing it? I am pinching it, taking it. Got the knot? Practice this. See, this is away thread, this is towards your thread. Away thread in your left hand. Right? Extend your index finger. Take this on your right hand. See, the loop is formed. Through this loop I am coming out, feeding this. Now see, once I feed this, you automatically get a knot formed. This is a simple knot. Got it? So this is away thread, this is towards your thread. Away thread in your left hand. Extend your finger. Bring this on your, go out. Right? Feed it, come out. You get the first knot. No. See, it's simple. This is away thread, this is towards you thread. Away thread in your left hand. On your index finger, which is extended, onto your thumb. So the loop is formed.
Yes.
Through the loop you have come out. Feed it. Bring it back. Goes away. this correct, wait, this has to go like this. If it comes like this, it's a granny knot. Got it? So you have to cross your hands. Please try only the first simple knot. Please don't tie this. I have not told you this too. Just do the first. See, do not try to do further exercise. Just do the same exercise again and again and again. That's it. Away. Your hands have to go away. Yes. See, if you pull it towards you, you will form a granny knot. See. If you pull it like this, it becomes a granny knot. So it has to go something like this. Now it's a proper knot. And the second one we'll learn, and this will square it. See, simple. Thread table. This is towards you thread, this is away thread. Away thread in your left hand. Extend your index finger. Towards thread on your thumb. Close it. लूप फॉर्म झालाय. या लूप मधनं मी बाहेर आलो. हे थ्रेड दिलं. 200 टेक्निक आहे ना. आला. सो काय झालं आता, जो टुवर्ड्स थ्रेड होता हॅज गॉन अवे अँड द अवे थ्रेड हॅज कम टुवर्ड्स यू. राईट. करेक्ट. So it has to exactly reverse. At every point of time, either your thread or your hand has to cross. Unless that happens, you will not have a square perfect knot. मला आता PPT दाखव. इथे दाखवली तरी चालेल. हां मुलांना दिसून येईल. ह्याच्या पुढची स्लाइड घे. पुढची स्लाइड. राईट. So I think up to this we have seen. Is it okay? Up to 8. We have come up to 8. Everybody? Those who still are not going to, is not forming the knot, please raise your hand. Anybody who has not yet got the concept clear? See, just because some structured instruction has been given, it is possibly you are thinking it is difficult. Just imagine, you are just tying with two hands, normal, anywhere. What will you do? You will do the same thing. It doesn't matter. The crux is you should know what is simple knot and what is exactly a perfect square knot, right? So we have done the first thing. Now the away thread comes back. You can see the away thread comes back, forms another loop through which your thread or the tail end comes out. Now the away thread comes towards you, and that would form a perfect square knot. Got it? So what happened is the away thread had come towards you. Now the towards you thread again goes away from you.
At the end of the knot.
Right? Again, see what has happened is until this time we have done. Now again we are forming a loop with the thumb, and away thread comes onto it. So this has formed a loop. For any knot we need to form a loop. Through the loop again I am taking this thread, right? This thread is fed to that pinch, which comes out like this, and you form another knot. So what I said was, initially we started with away thread in your left hand, extend your finger, form a loop, feed it, towards your thread goes away. Now away thread has to come again, form a loop, come out and form a perfect square knot. Got it? Perfect. So that is crossing the loop. The loop should be same, no? Loop should not be crossed. Right? Now extend it. Simple. Now if I do something like this, this is a Granny's knot. Hence I said it has to go away. Now the thread which has come towards you has to go away. Same केले की granny होईल. Show them the granny as well.
ग्रॅनी दाखवली मी त्यांना. सेम केलं की ग्रॅनीच पडते ती. हे असं केलं की मग ग्रॅनी पडते. हे गडबड झाली.
So you change your position. Now see, the same knot is correct. अशी केली की granny. Okay? Again, away thread has to come towards you. So here we have already gone on this side. So I am just forming a loop through which I am taking it out, and now this was towards me, it has to go away.
झाली झाली आली
Right?
दोन स्क्वेअर नॉट
आता पुन्हा एकदा लूप फॉर्म करायचं आहे. हे असं आहे आपल्याकडे. राईट, ह्याच्यावरती घेतलं, हा लूप आहे. हा लूप आहे की नाही? हे बघ. ह्या लूपमधनं तुला काय करायचं आहे? दिस थ्रेड हॅज टू कम लाईक दिस, साध्या भाषेत. सो हा टुवर्ड्स थ्रेड होता, हा अवे थ्रेड झाला पाहिजे. ही झाली परफेक्ट स्क्वेअर नॉट. वाईट दोन्ही खालून आले आणि त्याच्या खालून लूप आहे, ह्याच्या खालून दोन्ही गेले आणि आता हे हां हे थंबवरती घे. आता ते लूप फॉर्म कर, त्याला तेच दे. आता हे पुन्हा रोटेट झालं पाहिजे ना. हां हां राईट. आलं? ग्रॅनी हो गया ना. सो दिस इज ग्रॅनी. दिस बिकम्स, see this is a granny knot. This is a proper knot. See, so both the tails have to go away from each other. If they come like this, see this is a granny's knot. This is a proper knot. Now this knot is already tied. What you are forming is another loop. Now reverse. So supination to pronane here, opposite side. That's it. Perfect. Away. Correct. That's it. Got it? It can be done. With the same hand also it can be done. So instead of bringing on here, the thread has to go behind the thumb. And then with the same hand also you can do. Right? So with the same hand also comes. But opposite hand also, yes, it can be done. Now you have to turn it here, feed it, come out, go away. So the first knot is done, simple knot. 1 2 feed it, come out again. Yes. Now it has to come towards you. So this is the granny knot. It's not a proper knot.
So I'll bring this here.
You have to form a loop, right?
Yeah. Oh.
Yeah. Put it away and bring it here, and then this loop is there. So here you will have to change the hand. That's it. झालं का? Granny knot. It's a granny knot. See? It's not a proper square knot. You see? So a square knot has to be something like this. This is a square knot. Now the second knot has to be away. You see? So, everyone okay with this activity? All done? Comfortable? सेकंड नॉट नाही जमली अजून. So just form a loop. The idea is to form another loop. Cross होता है. That's fine. That's fine. इथल्या याच्यामध्ये you will have to change your hands. Here the hands would be crossed. What you are doing is you are looping already in a cross fashion, so you don't need to change the hands. If you go with this, you have to change the hands. The hands would be crossed. Granny? Yes. Got it?
Again, I have to come from this side.
Yes. Right? Ali? आता नाही आहे ग्रॅनी. दिस इज करेक्ट.
सेम थिंग रिपीट करा. फक्त ह्या साईडला करा. बरोबर. फक्त एकदा तिकडे बदलला ना, हात बदलायचा एकदा.
See, now what you are doing is you are leaving threads and again trying to regrasp. That is not done. You have to continue with the same motion. You are not supposed to leave threads like that.
आपण ते लीव थ्रेड्स करतो ना, दोन्ही हात सोडून मग बदलतो परत हात. कारण
Don't leave the threads and go again with the same knot. Because every time that is not possible, right? Don't. You're leaving everything. You have to continue with the same motion. Yeah, na? See this, you have done one with the same. You have to Just continue in the same sweeping movement. No. So many times you can't change and go on changing your hands, no? It has to be one simple motion. Take your time. Understand. Because you don't have another this thing. एक अजून एक्स्ट्रा आहे का? ते आहे ना एक्स्ट्रा? Ask for it, huh? Yes, एक थ्रेड आहे का रे? हो. Take this. मस्त का? तो छोटा होईल खूप. ठीक आहे. असं जुगाड. गाऊन लागणार आहे probably. Okay, so if two-handed technique is done, let us go for a single-handed technique. Okay, before that, a surgeon's knot. As I said, the first throw has 2 throws. So now, same 1 and again 2. Got it? Left hand, extend, thumb, 1. You come back to normal again, 2. Got it? And then complete the second knot, which is single. So first 2 throws, second single throw. Got it? Surgeon's knot, first simple has 2 throws. 1, you are already, now again 2. Right? So it gives 2 throws. Got it? And then complete your normal third knot. Got it? No, it's a granny. One, you are aware. Again, second. Got it? And then complete your second knot, which is normal. So first has got 1 and 2 throws, second has 1. So this is your knot. No, first you are already doing it, leave it. It's not like that. Away thread, holding it. 1, you are aware. Again go and take it out. These are 2 throws. And now complete the second knot. Okay? हे तुम्ही केलं ऑलरेडी. सेम 1. हे बाजूला घ्यायचे नॉट. नाउ अगेन युअर पिंच फिंगर कम्स आउट. गॉट इट? And then complete your second knot. So it would look like this. खालच्या 2 नॉट आणि वरची सिंगल नॉट. हा इज वेलकम. बरं आहेस? फिवर वाटतं अजून.
म्हणलं आता सगळ्या गोळ्या घेऊन
हा कुठे गेला?
विश्रांत बाहेर
त्याला सांग म्हणू तू चांगला घेतो. अरे खरंच सांगा ना.
ते माझं हे नाही आहेत मला
नाही आहे?
सो इन्स्टेड ऑफ कन्फ्युजिंग म्हणून मग मी बाहेर सो आय सेड आय शुड नॉट बी गोईंग अगेन.
ओके ओके.
कारण ते जे ते दॅट इज स्मॉल आणि लॉंग बी एस एसचं वेगळं आहे तो व्हिडिओ मला पुढच्या वेळी दाखवेल.
आहे तो पण आहे.
नेक्स्ट टाइम वी विल शो दॅट व्हिडिओ देन इवन यू डोंट हॅव टू एक्सर्ट सो मच. The video runs again and again and again, and they have to practice with the video again and again, and then the video also contains common mistakes. So that is there ready-made available. आता तुम्ही बघा तुम्ही आता व्हिडिओ माझा दाखवणार आहे या ह्याच्यासाठी. So everything is there on video. आम्ही जातो त्या कोर्सला we don't have to talk much. You have to just reinforce a few things. तर ती reinforcement तुमच्या लेक्चरमधनं मला मिळाली आहे त्याच्यासाठी सेशनसाठी.
Okay, we'll go with the single-handed technique. तू घेऊ लाग ना. तिथे पोरांना सांगायला पटापट बरं पडतं जरा. Okay, let us come to one hand technique. Now deliberately keep one end longer. Keep the left hand thread a shorter one. Okay. Now hold it in your 3 fingers. Extend your index finger. Extend your index finger. All looking at the look at the first picture. Look at the first picture. Hold it like that. Have you? Now your towards thread has to go and form a loop. See, it has come onto the index finger and formed a loop. Right? Now what you are supposed to do is, you are supposed to bring your short thread out. Now how do you do that? Just, this was the extended one on which a loop is formed. Now flex your index finger and take the shorter thread and bring it out. I'll repeat. The short thread comes on your side. Okay. The loop is formed. Flex it. Bring the short thread out of the loop. Go away. Now, all of you repeat this step first. See, I'll show. Deliberately keep this as a shorter thread. This is a longer thread, right? Loop is formed. Okay. This has to be brought and go away. This is called as index throw. Index. No. See, I'll show. One. And just continue. Yeah. ही कॉमन मिस्टेक आहे. लेफ्ट मध्ये पाहिजे. हे 200 टेक्निकली सेम केलं होतं आपण. आता हा लूप तयार झाला. काहीच केलं नाही. हे जे इंडेक्स फिंगर इज ब्रिंगिंग दिस कॉर्ड टुवर्ड्स यू. ह्याच्यातनं काढून घ्यायचं. संपलं. Perfect. And just continue the same action. तू एवढा नॉट का मारत बसली? आणि त्या चूक आहेत सगळ्या. ऑल आर फॉल्स. सी करून नको. मी रब करायला सांगितलं का काही? लूप झालाय. सी आय एम ब्रिंगिंग दिस कॉर्ड towards me and taking this out. Same movement. काहीच फरक नाही काय. नाही उलट केलेस तू म्हणून प्रॉब्लेम आहे. The shorter thread is on your left hand. Loop is formed. कॉर्ड इकडे ओढली तू. त्याला ह्याच्यात घेतलं. झालं. सेम ॲक्शन इज जस्ट कंटिन्यू. हातात थ्रेड आहे. इकडे घेतला. हे ओढून घेतलं आणि तिकडे कंटिन्यू. सी सिम्पल. युअर हँड इज हॅव्हिंग अ शॉर्टर थ्रेड. राईट. सो यू हॅव फॉर्म्ड अ लूप. ब्रिंग दिस. what I said, you just flex your index finger. एक्सटेंडेड होतं. हे झालं. फ्लेक्स केलं. So what I am doing is I am just continuing my action. Tang, ting, ting, and this simply goes away. Right? दाखव. ग्रॅनी. हां आता आली. हां एक पण ग्रॅनी येऊ शकते. इफ यू पुल इट लाईक दिस. राईट. दिस इज अ ग्रॅनी. गो अवे. बरोबर. आता ह्याला पण 2 वाली करता येते. 1 अगेन द सेम and 2. झाले. त्याच्यामध्ये जे डबल हँडेड ना, त्याच्यामध्ये आपण एक नॉट आता मागं पुश करायची. दुसरं Okay, all of you have done the first knot. It's simpler than 200 technique, I guess. Is it simpler than 200 technique or no? Second knot is even simpler than the other one. First knot everybody got it. Should I go on to second knot then? Okay. So now just look at my hands carefully. First was an index throw. So I got towards me a thread. Now I am just rotating it on my 3 fingers. I was having something like this, right? What I have done? I have taken everything on my 3 fingers. Bring it again back. I got a loop. Now it's the middle finger throw. Now the middle finger has to take the knot out. Okay. So this was my position. This was my position with the first knot. I am taking the entire thing on my left hand. Bring it back. So loop is formed. Now my middle finger bends, takes the thread away. So it's much simpler than a two-handed technique, right? Look at me. I'll take 1. Got it? This was my hand. I'm just turning it. See? जस्ट इंडेक्स फिंगर बेंड करत होतो पहिल्या ह्याच्यात, आता मी मिडल फिंगर बेंड केलं आणि याला बाजूला गो अवे. हां करेक्ट, गो अवे. दिस हॅज टू कम टुवर्ड्स यू ना. डोक्यामध्ये कॉन्स्टंट ठेव, टुवर्ड्स यू आणि अवे कोणता आहे. इट हॅज टू क्रॉस. अवे. Perfect. So look at me, the entire table. This was the index finger, right? Hala? Now middle finger has to bend. Do the same. Hala? Now this was towards me. It has to go away. No. नहीं, फर्स्ट पण दाखव ना, because it has to be in one motion. You are not supposed to roll anything, no? Loop is formed. This cord is with your flexion, simple, away, middle finger towards. आलं का रे? तोच हात. हे बघ, हा हात आपल्याला वापरायचाच नाही आहे, बिकॉज दिस इज आउट ऑफ फील्ड. दिस इज ओनली गिविंग मी द स्ट्रिंग, दॅट्स इट. सो व्हॉट आय हॅव डन, ठीक आहे. 1 गेला, हाच इकडे आला, मिडल फिंगर टुवर्ड्स मी. माझा फक्त हा हात काम करतोय, हे हात कामच करणार नाही, हा फक्त पकडून ठेवलाय. नाउ once you do both the knots with left hand, practice with right hand also, right? So दोन्ही हाताने तुला करता आलं पाहिजे. Simple, it's a concept basically. This is away thread, this is towards me thread. मी लेफ्ट हँडने पकडायचं सांगितलं होतं, लेफ्ट हँडने पकडलं, लूप फॉर्म केला, हे ओढलं. आता बघ, माझं फक्त लेफ्ट हँड काम करतोय. हेच टर्न केलं, इकडे आलो, मिडल फिंगर घेतला, इकडे गेलं. ठीक आहे. पुन्हा असा असा, राईट. सो मी या हाताला काहीच काम देत नाही, माय लेफ्ट हँड ओनली इज वर्किंग, बिकॉज इकडचं थ्रेड मोठं आहे, मला वापरताच येणार नाही आहे. पेल्विसमध्ये नॉट मारतोय मी. सो माझा हात कसा बसा आतमध्ये गेला आहे, एकच हात अवेलेबल आहे. सो इथे इन्व्हेरिएबली मिडल फिंगर बेंड होतं and it goes towards. So now इकडे येतो तेव्हा अवे, दिस होतं तेव्हा टुवर्ड्स मी किंवा अवे थ्रेड. जस्ट टू अंडरस्टँड, बाकी काहीच नाही, राईट. 1 गेलं. आता हे अवे थ्रेड झाला. अवे थ्रेड हॅज टू कम टुवर्ड्स मी, तरच क्रॉस होईल. आला इकडे, दिस हॅज कम टुवर्ड्स मी, तर माझी नॉट परफेक्ट येईल. हा जर मी पुन्हा अवेच करत बसलो तर ग्रॅणी पडत जात. आता अवे दुसऱ्या हाताने कसं करायचं? सेम राईट, सेमच केलंय मी, फक्त आता लेफ्ट हँड कॉन्स्टंट ठेवलाय आणि राईट हँडनी करत बसलोय. सो लेफ्ट हँडनी करून बघितलं. नाव डू द सेम विथ राईट हँड. व्हॉट डज दॅट मीन? माय लेफ्ट हँड इज कॉमन कॉन्स्टंट, ओनली राईट हँड इज वर्किंग. हां ठीक आहे, दिस इज परफेक्ट. दिस इज करेक्ट. हो, दिस इज करेक्ट. ओके, correct, everything is correct. Now do with the opposite hand. बरोबर. See, the same thing has to be done again, no? Right. Same. So my only right hand now is working, left hand is not working. पण हे कुठं आलं? इकडं का तिकडे? So that would form a granny knot. So right? So मी म्हणलं तसे दोन्ही हाताने करून बघायचं. सो अवे थ्रेड या हातात, लूप इंडेक्स 1 आउट, मिडल फिंगर मीन्स अवे, तर परफेक्ट नॉट आहे. राईट, हे झालं एका हाताने. आता राईट हँडने करायचं या हाताने. हा हात कॉन्स्टंट आहे. अगेन लूप, स्ट्रिंग, इंडेक्स फिंगर towards me, heart towards. Ata this goes away from me. So this once comes on this side, once goes away. Towards me, away. Towards me, away. Okay, so single-handed and double-handed. Which one is simpler? Which one is simpler? If that is the case, then probably I am not a better guy to demonstrate. But I guess the single-handed technique is much simpler and faster. You can work on it with both the hands. Okay, let us now move ahead quickly to the last session, and that is an instrument tie, the instrument knot. Now you have got, everybody has got a pad. There is an incision which is already marked. Please take one tooth forceps in your hand, right? Needle holder, take the needle holder. So there is an exercise. One is locking a needle holder, opening it, lock it, open it, lock, open. Now the ratchet has got 3 serrations. The first serration is just to approximate. All 3 would fix the needle, right? So every time you need not fix the needle with 3 catches. With single catch you can easily lock the needle and do your job. Now ideally we always say that your thumb goes in one of the finger bows, the index finger goes in another finger bow, your middle finger stabilizes the instrument, right, and the index finger just manages to rotate it. This is the grip of a needle holder. But now we always say that you need to pierce the suturing part at right angles. If you have to go right angles, see how my hand is working. You have to do a lot of pronation, supination and so on. Instead, if you hold the needle holder in a palming technique. This is known as palming technique. Now I am very comfortable. I am just rotating my needle holder in my hand. See, I need not do lot of pronation and supination. I will demonstrate now. So this is needle holder. One is a classical technique, second is palming technique. This you can work easily with your thumb and close it with your thinner eminence, right? So just practice opening, closing, open and close, and palming technique also, right? This is one experiment. Now second is, the suture material is provided to you. How to open it? Just simply open it, take out the pack. Now open the flap. Open the flap and you will see the needle is secured in another fold. So simply catch the needle and take out the thread. Now I am not supposed to touch the needle any time. Can you see how I have worked on it? I have hold somewhere arbitrarily. Now I am not catching the serration. I have just hold it tight enough not to slip, and then just turning in, rotating it with the forceps. Or you can hold in forceps and then you can adjust your needle holder. Now where to hold the needle in your needle holder? Remember, there are many sizes of the needles. Am I audible? All the tables, just look at me. Look at me. We'll do it afterwards. So the needle comes in various sizes, as I said. 1/8 circle would be lam, very. ये मला 20 है देना इथिलॉन. Okay. And 5/8 circle port closure needle, you must have seen. It's very short, stout. Now where to hold the needle in your needle holder? Remember, the anterior 1/3 and posterior 1/3 is the area which should never be held in your needle holder. Now the needle holder has to hold somewhere at the junction of anterior 1/3 and posterior 2/3, or the exactly opposite, in between, anywhere which is comfortable. Now why this is so is, when you want to work in depth, your needle size is small, you will hold slightly anteriorly, right? Because you get a firm grip. You have to just pass through the tissue. When it is on the superficial surface, it can be somewhere in the middle where you can get a better chunk and hold the needle. The idea is your needle has to be hold in between this area, between 2/3, middle 2/3, anywhere at the tip of the needle holder. At the tip of the needle holder, because then that becomes a very easy grip to pass through the sutures. So once I lock it, it has to be, as I said, perpendicular to my first pass. Now to make it perpendicular, as I said, I have to pronate my hand. Can you see? I have to pronate my hand. Against that, just look at my hand now. I am comfortable. Is it correct? So you will practice both ways, but the classic teaching is in your finger bows. Now with the opposite hand you will just evert the edge and then pass 1 centimeter away and bring it out. Right? Now again look at my hand. I am just taking the curve of the needle like that. Okay? I have not handled the needle, so I am not supposed to touch the needle any point of time. With the forceps I am grasping it, again readjusting it. Right? Now the second edge, again perpendicular, and just come out arbitrarily 1 centimeter away from the skin edge. Again I am not supposed to take it out horizontally. I have to take the curve of the needle. And now don't touch the needle but leave it dangling somewhere. Then that becomes a passive needle. This is known as an active needle when I lock it. This is always a dangerous needle because it can injure your hand. This is a passive needle. Even if it touches my hand, it will not cause any injury. So never hold the needle any point of time. Now look at this. You have got a short thread, you have got a long thread, and we are going to do the same which we have learnt. So the first throw is completed. See, my needle holder is just going above and catching the distant thread. Now you can see it is forming a loop, right? And this is my first simple suture. The same knot which we tried with the single-handed and two-handed technique. Is it clear? I'll repeat. This is my away thread. This is towards me thread. Towards me thread, one loop is created. Through the loop I am taking the tail towards me. Right? This is now towards me thread. Now what has to be done? Towards me thread has to go away from me now with the second loop. Now you can see my thread is in my hand. So here only I rotate, form another loop, right? And it has to go away. The knot has to always come on one side of the incision. Right? So what I did, one throw towards me, same rotation away. Right? So this is very important. If I take this first thread and I don't continue with this, if I go again like this, then there would be a granny's knot. Okay? So the instrument tie is same as whatever we have learnt. A loop, tail end through it to form the simple knot, reverse to complete the square knot. Right? The knot has to come on one side of the incision. It should never be on the incision side. You can practice this.
फार मागे नाही येणार ते.
मला म्हणजे जाता येता येईल ना.
हं. I hope everyone is settled. Hello. I hope everyone is settled. Yeah? Yeah. So the next session we are going to have is the bowel anastomosis or the intestinal anastomosis. So of course for the postgraduates it is mandatory. For the interns it's good to know. And bowel anastomosis in general surgery is an essential skill which you need to possess, right? So what is bowel or intestinal anastomosis? It is a surgical procedure to establish communication between two formerly distant portions of the intestine. So there is a pathology, you cut the pathology, you excise the pathology, and you are left with two ends of the bowel. And anastomosis is joining the two ends. So basically it is restoring the intestinal continuity after removal of a pathologic condition. So it can be anything, it may be a tumor, a stricture, a gangrenous segment. You cut and you are left with two open ends which you have to anastomose. Now this is a very basic and very important procedure, because if the anastomosis leak is there, then the entire surgery is going to go waste and it can be fatal also. So basic suturing techniques in the bowel have to be learned. So just a background, you know that bowel layers, how many bowel layers are there? So mucosa, submucosa, the muscularis layer. So entire GI tract, it is the inner circular and the outer longitudinal. So but together for practical purposes, we'll consider it as a muscularis layer, and then the serosal layer. Few portions of the gastrointestinal tract, they lack serosa, but the small intestines, large intestines, they have serosa. Which are the portions which lack serosa? Esophagus and a portion of rectum, right? But predominantly along the entire continuity of the bowel, we have got these standard layers of the bowel. Knowledge of this is very important, because which layers to take and which to exclude or can be excluded is necessary. Mucosa may or may not be taken, but submucosa always has to be taken, because it serves as the strongest layer in an anastomosis. So submucosa always has to be taken. Yeah. So what are the methods of anastomosis? It can be an end-to-end. So there are two ends, you are joining one end to the other, then end to side, one end to the side of the other, and side to side. And intestinal anastomosis now can be done by two techniques. One is the hand sewing technique, and second is the staple technique. So today we are going to learn about the hand sewing technique, because the hand sewing technique, the knowledge is must. You have to possess that knowledge, because staples you may get or not get, but the basic is the hand sewing technique, and it can be in a single layer or a two layer. A single layer of sutures, anastomosing, and two layers. Of course it is concentric. Many a times while reading also you might come across the terminologies like third layer and the fourth layer. But in practice, if this is a portion of one side of the bowel, this is the other opening. So if you go like this, first layer, second layer, third layer, and fourth layer. But actually it is a concentric, so it is two layer. If you count it like this, it will be a four layer. This I am telling because many a times in few textbooks you will find the terminology, the third layer and the fourth layer. So in practice it is either single layer or two layer anastomosis. So just the theory part which is essential, the tenets of good intestinal anastomosis are adequate exposure and access, gentle handling of the bowel, adequate hemostasis, approximation of well vascularized bowel, and absence of tension at the anastomosis. And lastly, it is the good surgical technique which we are going to learn today, the surgical technique, right? You need to master only 3 types of sutures for a good bowel anastomosis. One is the Gamby stitch, the second is the Lambert stitch, and a Connell stitch. We are going to learn about each one of them in detail. A Gamby stitch is the classical Gamby stitch. Just pay attention to the board, right? These are the 2 ends of the bowel, right? Serosa, muscularis, submucosa, and mucosa. right? So in a Gambi stitch, the first bite, it goes through all the layers, serosa, muscular layer, submucosa and mucosal. On the same side, you turn U and go up to you take the mucosa and the submucosa, and then go to the other side, again take the mucosa and submucosa and come out throughout all 4 layers of there, and then you approximate. So these two are going to get approximated and there will be no mucosal pouting. The simplest stitch is all 4 layer stitch. All 4 layer stitch, like simple stitches you have learned today, the same technique also can be used for a single layer anastomosis, but many a times what happens, the mucosa pouts out. If the mucosa pouts out, there will be a chance of leakage. So that is prevented in a Gambi stitch, right? A simple suture would be, you go through all layers, you come on this side and then come out, right? But what happens in that case, this mucosa tends to pop out. In Gambi stitch, you are suppressing the mucosa and submucosa inside, and the serosa, it covers nicely the mucosal and submucosal layer, right? So this is the Gambi stitch. Then the Lambert stitch. Lambert stitch is a sero-submucosal layer. So if this is the wound edge, it's a covering layer, it's an inverting layer. You have done the first layer and you're covering the first layer with the second layer. The second layer is the Lambert stitch. So you go inside on one side around 8 millimeters from the edge of the wound and come out sero-submucosal, not full thickness, and come out on the same side approximately 3 millimeters from the wound edge. And then you go on the other side again 3 millimeters from the wound edge and you come on the same side from approximately 8 millimeters from the, so this distance will be around 5 millimeters, right? This is at 8 millimeters from the wound edge. You come out on the same side, a sero-submucosal, around 3 millimeters from the wound edge, and then you go on the other side 3 millimeters from the wound edge and come out around 8 millimeters on the same side, and then you approximate. So that covers the first layer. So it's the Lambert stitch layer, it serves as a covering for the first layer. Just a minute. That is the cornel suture. So cornel suture, usually it is at the 2 ends of the bowel. So these are the 2 cut ends of the bowel, right? These are the 2 cut ends of the bowel. So it is usually at the corners of the anastomosis, the corners of the anastomosis. And we started as outside in, inside out, then go on the next side, outside in, inside out, and then you tie it. Got it? So outside in, inside out, outside in, inside out, right? So that will give us secure closure of the ends of the bowel. So this is just to show the 2-layer hand sewn anastomosis. We'll be practically doing that. Now here you can see the 2 ends, right? 2 ends of the bowel are approximated or brought closer with stay sutures and this Lambert suture, that is the posterior most layer is taken with a Lambert suture. Then you have got, or you can call it as the fourth layer. Then you get the posterior inner layer. So this can be called as the posterior outer layer, then the posterior inner layer, and then you come anteriorly. So anterior inner layer and the anterior outer layer. So the outer layers are going to be the Lambert sutures, right? So to begin with, the two cut ends of the bowel are in close opposition, and stay sutures are of 30 vicryl between the serosa of the proximal and distal ends, approximately 5 millimeters. So you will take a stay suture here, just to approx, and on this side also. Yeah, just to bring these two ends closer. And then interrupted seromuscular layer, like the one I showed you for the posterior outer layer. This one, it can be interrupted or continuous. This is the posterior outer layer. Then the Connell stitch is made at both ends. This is the Connell stitch, right? Outer, out to in to out, out to in to out. And then the anterior inner layer, like we saw here. This is the anterior inner layer, which is then closed with the anterior outer layer. That is again the Lambert suture. So if you take a cross section, this is going to be a standard 2-layer anastomosis, right? So the first layer is almost the entire, it is covering all the layers of the bowel, and this is the Lambert. It is only serosa and submucosa. Submucosal. The mucosa is not included in this layer. A single layer, it can be done by a simple all coats suture or a Gamby stitch, right? So in a single layer anastomosis, there is no Lambert suture, or there is no covering of the first layer, right? We'll now move on to the actual practical demonstration, because all of this cannot go into your heads at one go. So step by step, each stitch will demonstrate, and you have to perform that stitch in the models, right? Hey, ikkade June. You can divide the bowel in the center. You can give a cut, make it into 2 pieces, right? येते This thing? Yes. Can everybody see? Just divide the bowel from the center so that you have got two open ends, right? We'll start with a stay suture at the ends, right? The stay suture so approximately 5 millimeters from the cut edge, you take a stay suture. 5 millimeters from this cut edge, we take a stay suture, not full thickness but zero submucosal. Same on the other side. Yeah, and then you tie a knot. And you hold it with an artery forceps. Same way, you take a stay suture on the other side also. Approximately 5 millimeters from the cut edge. Go to the other side. Are you getting? So there are stay sutures on both ends, right? These stay sutures will help the both ends of the bowel come together, right? Now, we'll start with the cornel stitch, which is at the corner, right? So the cornel stitch, we start from one end, outside in, inside out, on one side of the bowel. So this is the corner, yeah? Outside in, full thickness. You come into the lumen. And then inside out on the same side. Getting it? Yeah? Now on the other side, same, outside in, and inside out. and then you tie it outside. Did everyone get it? Outside in, inside out on one side, move to the other end, outside in, inside out, and then tie the knot. That is a Cornell stitch. Yeah? I am repeating it on the other corner also. Outside in, inside out. And then outside in, inside out. Hmm? हे येत आहे ना
आउटसाइड इन
हम्म.
जवळून इनसाइड आउट झालं तिकडच्या बागडल्यानंतर जवळून आधी आउटसाइड इन असतं आणि मग आउटसाइड इन
एक
दिस वन ना
हम्म. 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 हो बरोबर हां हे
farther and near and नंतर near inside
this can be a continuous cornelling also. हां
सगळे स्टेज विचार काय हे छोटं घेत आहे
हो
त्यांना जर सांगा की दोन स्टेज विचार
हां stay sutures you can take shorter also. Stay suture के हम्म. स्टे सुचर आर्टरीने पकडून ठेवायचं. हां, नाव गो आउटसाइड इन, inside out on the same side, inside out on the same side. Now outside in, inside out. नहीं नहीं, on the other side. काढून घे वाटल्यास आणि मग परत इनसाइड आउट. या या right, and then tie the knot. Yeah, so this can be done in a continuous fashion also. That is called connealing. Yeah, at the edges you have to do connealing, but you can do it throughout also. Yeah, full thickness. Any doubt? लॉक नाही होणार. नाही, त्यातून का घेतोयस तू? Got it? Got it? हाँ, correct. This is a stay suture. After that, just थोडंसं बारीक घे, लहान घ्यायचं स्टे सुचर, ओढून घे आणि एका एंडला आर्टरी लावून हे करून ठेव. ते हे काढ, नॉट काढ, म्हणजे सुचर वाचेल ना. Right. Now you can practice the Lambert suture. त्याला कंटिन्युअस कॉनेलिंग म्हणतात. एक सिंगल घेतला तर सिंगल कॉनेल सुचर. Attention please, all of you, we'll see how a Lambert suture is taken. Attention all of you. Yeah, a Lambert suture. Yeah. So now if I want to bury this suture, I have to take a second layer, that is a Lambert suture, right? So this is the cut edge of the bowel. I am going to take a bite around 8 millimeter from here, come on the same side, around 3 millimeters from the cut edge, come out. Now go to the other side, again 3 millimeters from the cut edge, and come out around 5, at a distance of 5 millimeter from the first bite. Yeah, and then you tie it. So you can see the first layer, it is buried beneath this layer, right? So serosubmucosal on one side and serosubmucosal on the other side. Got it? We'll repeat it. We'll repeat it. On one edge, around 8 millimeters, come out around 3 millimeters from the cut edge. Then on the other side, go in at 3 millimeters and come out at 8 millimeters, right? And then tie the knot. So that will bury the first layer. So that is the Lambert suture. You can practice the Lambert suture now. पता है? Which suture? Limbert? हाँ. Any doubt? No. Correct. And same on the other side. Correct. नाही आता इकडूनच घे. हां करेक्ट 3 to 8. Any doubt?
First we have to close this, then on the posterior aspect this, and then this and this. Na?
Correct. Correct. Yeah, attention please. Yeah, attention please. Everyone. 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 Attention please. Yeah. We'll see the all coat suture, that is the needle piercing through all the layers of the bowel. But during anastomosis, you should always take more of serosa, muscularis and submucosa, but less of mucosa. So if you are taking all coats or all layer stitches throughout the entire circumference of the bowel, you have to take in the bites more of serosa and submucosa and less of mucosa. So it's a simple stitch, but only thing is that the mucosa has to be minimal. So this is the way it can be done. You hold the edge of the bowel. So you take around 5 millimeters from the cut edge, the bite, right? You come inside, but less of mucosa. Go to the other side, less of mucosa and more of the other layers, right? So it's a simple stitch, but taking less of mucosa will invert the mucosa and the mucosa will not pop out. So it's a simple stitch which you have practiced it on the model upstairs, right? So it's a all coat stitch. This can be continued throughout the circumference of the bowel. In an interrupted fashion. less of mucosa and more of the other layers, and then a simple stitch. Hmm. Hmm. Sorry?
Inside out, inside,
Hmm.
outside in, inside out curly, upper and the other.
Hmm.
From this stage feature to this stage feature. Then what we have to do?
See, you have got the posterior layer. This is the anterior layer, right? This is the anterior layer, right? You have got, so you can continue this anterior layer by a simple stitch continuous or cornelling stitch continuous. Cornelling is inside out, outside in, inside out, and then go to the other side, outside in, inside out. Then again in a continuous fashion. You start. Nahin, now you have to come out, no? You're in, right? You're in. You have to come out. From that side only. From that side only. You're in, no? You come out. You have to hold the needle in the opposite fashion. Yeah, come out. Yeah? Now go to the other side. Right? Outside in, inside out. Then go from outside to the other side. Do it. Outside in. Yeah. And then rotate. Hmm. Inside out. Right. Now you are out, right? Now go on the other side. Similar fashion. Outside in, inside out. Then on this side, then on that side. So that will be known as continuous cornelling. Hmm? आता कोणता घेतेस? ओके, कॉर्नेल घेतेस का? Outside in, inside out, and then the same on the other side. आता हे झालं. हा असा तू पूर्ण लेअर घेऊ शकते पूर्ण, आणि मग हे क्लोज करण्यासाठी तू लेम्बर्ट घेऊ शकते. मग इथून टाकायचं, इथून काढायचं, इथून टाकायचं, इथून काढायचं. नाही, हे पूर्ण घेतल्यावर प्रॅक्टिस होऊन जाईल तुझी फुल लेंथ, आणि मग ते कव्हर कर. काय 2-1 2 थ्रोज आणि मग 1 थ्रो. हां, that will secure it. बरोबर बरोबर येते. Now this is a corner stitch, but this can be done through the entire length also. That is known as continuous cornelling. हा सिंगल कॉर्नेल सुचर झाला. तेच तू एंटायर लेंथला केलं तर दॅट इज नोन एज कंटिन्युअस कॉर्नेलिंग. हे तुझं आहे का इथलं? हम्म. हम्म.
कंटिन्यूस पीस से करना है ना,
यू कैन.
यहाँ से है
अभी कहाँ हो?
ये अलग
इनसाइड है. यू हैव टू कम आउट, है ना? और आर यू आउट ओनली?
आउट हो गया, ये है
विच इज योर एज?
दिस ना, हाँ दिस ना,
Just a minute. See, this is the posterior layer, है ना? ये भी posterior है, ये भी posterior. अब ये posterior, you have to do it continuous. Continuous. So less of mucosa and more of serosa.
okay, we don't have to do full thickness, only
Full thickness you can, but you take only small amount of mucosa, but more amount of serosa, right? So if you are taking a bite from here, more amount of other layers and come with a thin layer, come out with a thin layer of mucosa. Now, no, now you complete the posterior. You can do it continuously. Yeah, do it. Yeah. So that can be intermittent or continuous. Hmm? Continuous up to the head. And in the corners you will take a cornelling. Cornelling in the sense you're inside, right? Continuous. Then come out. Once you come out, you can do a cornelling. Out, in, out. Out, in, out. So at the ends, it has to be a cornel suture. Yes, correct. Correct. Hmm?
स्टेज सुचर घेतलाय,
Hmm.
कंटिन्युअस केले. आता लास्टली काय करायचं? झाले पूर्ण कंटिन्युअस मध्ये.
हां, मग लास्टला कॉनेल घ्यायचा.
कसं आहे?
आउटसाईड आहेस ना तू? आउटसाईड आहेस ना तू? आउटसाईडवरून तिथूनच आउटसाईड इनसाईड आउट आणि मग दुसऱ्या बाजूला जायचं. लास्टला सगळ्या कॉर्नर्सला कॉनेल पाहिजे, म्हणजे ते आतमध्ये जातं. आता तू बाहेर आहेस, बरोबर? बाहेर आहेस ना तू? हां, तू आता आत जायचं आहेस, म्हणजे निडल तुझी उलटी पाहिजे. आ ते लॉक झालंय. मग आता तू बाहेर आलायस ना, मग ह्या बाजूनी आउटसाईड इनसाईड आउटने बाहेर यायचं. आता तू बाहेरच आहेस, है ना? बट कम ऑन दिस साईड. नाही उलट, आउटसाईड इन ना, तू बाहेर आहेस. हां, मग आउटसाईड इन जा, मग इनसाईड आउट घेताना उलटं करावं लागेल, बरोबर? करेक्ट. हां, आता यू आर इन टू द ल्युमेन. नाव यू हॅव टू कम आउट ऑफ द ल्युमेन. मग नीडल उलटी करायची, है ना? सेम साइड. ठीक आहे, आलं? आता बाहेर आहेस, तुला परत कॉनेल करायचं असेल, तू त्या बाजूला आउटसाईड इन इनसाईड आउट करशील.
लास्टला याला जॉईन करायचं.
हां,
त्याची स्थिती घ्यायची.
नाही, आता हे तू कंटिन्युअस आला ना, तर सुरुवातीला काय असतं, सुरुवातीला यू कॅन तुझं स्टे सुचर्स होते आधी. हां, मग तू यू कॅन एंड इट हिअर, यू कॅन सुचर इट विथ दिस, तिथपर्यंत येऊन. हां
तिथपर्यंत आलो आता.
हां, ठीक आहे. आउटसाइड इन.
पहिल्या 3 स्टेप सेम राहतात, चौथी स्टेपला एक खाली
हम्म.
पहिलं बांधून मग तो सेम लेवलला घ्यायचा, दोन्ही सेम लेवलला घ्यायचा, म्हणजे तो इंटरप्टेडवाल्या कॉर्नरसारखा घ्यायचा आणि मग त्याच्या खालनं आत घालायचं, कट न करता.
हम्म. आता काय, आता कुठे केलंय?
And then you went inside out. Otherwise, ideally you should have gone outside in. तर ते दोन्ही खाते झाले.
आता तू बाहेर आली आहेस ना, हे काढून टाक माझं. आता हे तर झालंच, हे पण Hello? 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 Attention. You can practice side to side anastomosis also. Like side to side anastomosis. You can see, you can give a cut. I have given a cut on both sides. Right? Side to side anastomosis also. This is the posterior layer which I have taken, right? Now I'll take a cornel stitch here, outside and inside out, and from here. So that is the corner stitch. And then go inside and then continuous outside in, inside out, then on the other side, yeah, so that will secure the edges, outside in, inside out. So in a side to side anastomosis also, at the end you will get a cornel stitch. Right? Now you can see the posterior layer, it gets hidden behind this. Then you can go inside and have a continuous layer. Go inside and then the posterior inner layer, full thickness, less of mucosa, more of serosa, more of serosa, less of mucosa. This you can do it in a continuous fashion. So that is the posterior inner layer. So this will be a side to side anastomosis. So ultimately there will be one lumen. Then coming at the ends, again you can do a corneling. Now you have come out, outside in, inside out, then go to the other side. Outside in, inside out. And then you can start with the anterior layer.
uh, even for orthopedics and gynae also, I think vascular repair becomes one of the life-saving and sometimes an emergent procedure. So you must know at least fundamentals of vascular repair. You can save at least one patient sometimes. Even that is sufficient, I guess. So vascular repair. I invite Dr. Karad, who is a plastic surgeon with us. So he'll be taking you through the vascular repair, and then we'll have hands-on vascular repair. The specimen is already mounted in front of you. You'll have your instruments, and we'll proceed further. So Dr. Karad, please continue.
Thank you, sir. Hello. Hello, guys. Are you ready? हे सब पूरा करें. Next point. इतना ना. Hello, everyone. Please be seated. Please be seated. So good afternoon everyone. लंच हो गया मस्त एकदम ठीक ठाक. अभी बस नींद आएगा थोड़ा सा ज़्यादा लंच के बाद. थोड़ा सा कंसंट्रेशन दीजिए. जल्दी से ख़त्म करते हैं अपना ये थ्योरेटिकल पार्ट. थोड़ा ही होगा, बाद में हम वर्कशॉप पे जाते हैं. ठीक है, प्रैक्टिकल करते हैं. सो these are the just fundamentals of vascular repair, right? Before going to the vascular repair, why do we need to understand how vascular repair is done? So the cause is vascular trauma. We come across a vascular trauma for which we need to repair that vessel, right? How to identify there is a vascular trauma? First you have to identify there is vascular trauma, then we will think about repairing that vessel, right? So these are some hard signs which will direct you that you have done something while operating, or you have got a patient whose vessels are ruptured or whose vessels are teared. So this is pulsatile hemorrhage. This is very pretty much common sense. There is a lacerated wound or cut injury and direct frank arterial, bright red arterial blood is continuously sprouting through that wound. This is the most common thing which you will come across, ki this is the hemorrhage or this is the vascular trauma patient. Then there is when there is no external wound, but you are seeing a patient where there is a blunt trauma, and you are suspecting based on his vitals that something is going on and his blood pressure is dropping down. So you have to search for some expanding hematoma inside his extremities, where you can think about there is internal bleeding going on, right? Third thing is palpable bruit. This will occur when there is arteriovenous shunt or arteriovenous fistula has occurred after the injury of the vessel. And these are the distal ischemia signs, like if the extremity is ischemic, like vascular injury has caused obstruction of the blood flow or loss of blood flow to the extreme part of the foot or hand, then you will see all these 6 P's we say, like pain, pallor, pulselessness, paresthesia, paralysis and poikilothermia. Everyone knows all these things, right? Ischemia, these are signs of ischemia. When you get patient of these symptoms, you should suspect about the vascular injury. Then what we will do, we will think about doing a damage control first and then definitive repair first. Actually there is no slide of investigations what you should do. After vascular trauma, the most important sign is arterial or arteriovenous Doppler or CT angiogram, which will give you a definite view where the exact injury is and where you should open that particular extremity, right? Then you know that this is the patient with vascular injury. You should think about saving the life of the patient rather than first going to saving the limb. So life over limb is the basic concept, and how we can save the life if there is a massive bleeding, and if you ligate that blood vessel right now, you are going to lose the limb. But that ligation will help you to stop blood loss, and we can save the patient. Then you should think about ligating that vessel, because anyways we can repair that vessel after some time. So first, life over the limb is the principle. So ligation of the vessel or temporary shunting and packing. We say how to stop the bleeding: pack or pressure. Give pressure or do packing and stop the bleeding. So stopping the bleeding is the first concern. Then after that, we will go for the definitive repair. Right. So the goal of definitive repair is to complete restoration of the blood flow to that part distal to the vascular injury. Right. It will contain the steps will contain debridement of the vessel, which is pretty much damaged, and tension-free repair of the vessel. So what is the ischemia window? I think all of us know that 6 hours is the ischemia window. What happens after 6 hours? After 6 hours, the nerves or muscles start getting hypoxic tissue damage, and myonecrosis or nerve damage starts occurring after 6 hours. So we cannot save the functional limb after repairing vessels after 6 hours. So we prefer starting anastomosis before 6 hours. So just remember this 6 hour wala funda. You will need this throughout your life. Whenever there is injury, within 6 hours you have to repair the vessel. These are few ways or few options in which the vessel is repaired. First is primary repair, where two cut ends of the vessels are repaired. Second is patch angioplasty, where there is longitudinal injury to the vessel, and you touch screen. So if there is complete transaction, then you will do primary repair. If there is longitudinal cut injury, and if after suturing this cut we are seeing the lumen of the vessel is getting pretty much narrow, then we will do the patch angioplasty. Third option is interposing a graft or artificial material, where there is a lot of gap between the two cut ends of the vessels. Usually we say more than 2 centimeter is the criteria. After having a injury of 2 centimeter, we have to go for the artificial graft. And fourth option is bypass grafting, that the vessel is totally damaged, but we want to supply the blood to the distal part as soon as possible. This can be considered as a damage control also. So we will bypass that particular damage segment, and we will apply a graft from the proximal to the distal most portion. Then we have decided, like, we want to do primary repair, we want to do plasticity, whatever the concept is there. Then after actually suturing the vessel can be done with the two methods, like continuous suturing, and you must have just now done the bowel repairs. Similarly, here continuous repair or intermittent repair or interrupted suturing. Both methods are there. Which method is best, which method is bad? It is not like that actually. It is person to person, it varies person to person. Someone prefers continuous suturing, someone prefers intermittent suturing or interrupted suturing. Few people prefer to do half continuous suturing and half intermittent suturing also. So basic thing is suturing proper wall to wall or intima to intima close suturing is very important. How you do is secondary, but what result you get is more important. Exactly step by step, continuous, intermittent, we will see in the practical version only. Here you can see what are the benefits or what are the drawbacks of each method. The advantages of continuous method are, it is faster, no need to apply knot every time, so it is faster. There is good hemostasis, it is considered as continuous method applies good hemostasis. But the problem is, if the suture breaks, one of the suture breaks, then you lose the continuity, and then again you have to start from the beginning, or you have to take few intermittent sutures also. In intermittent suturing, you can see there are multiple sutures, so the material, foreign body material which we are applying will be more. This is one of the drawback, but the benefit is when you complete the anastomosis and you find a thrombosed vessel after anastomosis also, you can remove one of the suture and you can flush that vessel and you can resuture one suture so that the anastomosis can be freshened easily. Now this is vessel preparation. Now you have decided whether you will repair the vessel continuously or intermittently. After that, the first step of operating will start from the preparation of the vessel ends. So basically, whenever there is trauma, some part of the vessel gets damaged. So we don't want to suture the damaged part to each other. We want to get a fresh part of the vessels, and we will suture that wound. In case of elective injuries, elective cuts or elective anastomosis of vessels, we don't need to discard any part. We can cut the vessel and we can directly suture at that site only. But in case of traumatic vascular injury, we have to remove the damaged part. Like this is the damaged part. So we have to go up to here where we will see a fresh blood vessels and we will repair that area only. The another concept is what will happen if you have a small vessel at one side and there is lumen discrepancy on both the sides, proximal and distal ends are not matching. Then we can think about spatulation. So spatulation concept is most preferably for that. But even in case of similar luminal area, we can do spatulation of the vessels, because what we say in plastic surgery, whenever we do a straight line suturing, the scar will be more. So if you are suturing those vessels like this, there will be a constriction ring around the vessel and it will cause luminal narrowing. But if we do spatulation, so we have one vessel like this, another vessel is like this after spatulation. So if we suture vessels like anastomos vessels like this, so there will be an oblique scar. So the narrowing of the lumen will be less. Now the anastomosis can be done in end-to-end manner, end-to-side manner, side-to-side manner, or grafts, right? End-to-end manner can be continuous or interrupted. End-to-side manner can be continuous or interrupted. Both can be done, right? So first we orient the vessel. We will apply the vascular clamps over here because there will be continuous blood flow from the proximal end, and most of the times from the distal end also there will be blood flow because of the circulation of the extremity, right? Then we will keep the spatulated ends approximating to each other. We will apply the clamps. Vascular clamps will be there. There are double clamps or single clamps. Double clamps will be like the clamp will be here, and there will be two prongs which will keep two cut ends of the vessels together, and we can repair. There will be less tension in that method. After anchoring, we start with the first two sutures. Like anchoring sutures will be given here and here, and then we will go for the posterior wall first, because after suturing anterior wall we cannot go easily to the posterior wall. So we do first posterior wall first, then the clamps will be reversed and we will do anterior wall. This is end-to-end anastomosis. For end-to-side, we will do a arteriotomy. Spatulation is very, very important for end-to-side, because if we don't do spatulation and you anastomose the vessels directly like this 90°, there are higher chances of forming a thrombus in that case. So there should be a spatulation in end-to-side anastomosis. And after doing spatulation, this end, which is you can see this is the acute angle. So we have to suture this angle first, then this angle, then posterior wall, then anterior wall. Right? This is end-to side. The third thing is side-to-side anastomosis. This is very rarely needed. This is usually needed in case of AV fistula surgery. In case of traumatic vessels repair, we don't need side-to-side repair. Then this is patch, or what we saw in the first slide. There is a patch. The patch can be of our own great saphenous vein, or it can be of artificial material, PTFE, and we can suture, we can apply that patch over that particular damaged part of the vessel. Usually this is not done usually. What we prefer, if there is injury, we suspect that there will be injury to the posterior wall also. So we don't want to keep that posterior wall which is damaged. So we will cut these ends from here and we will do fresh end-to-end anastomosis only. This is very rarely done. Right? Now this is parachute technique. What is parachute technique? If the anastomosis is happening in the very deep area and we are not able to look at the posterior wall, anterior wall, where is the wall, where is the suture going in, we cannot separate the anterior and posterior wall. We feel that we may take suture from the posterior wall and it may come out from the anterior wall. We can take both the walls. In that case, the parachute technique, we take sutures and keep them loose. And after taking 3-4 sutures, we will pull the suture so that later on the vessels will come together. So we don't put vessels together right now. We keep them separated so that we can see the total lumen of the vessel, and then we will pull the suture and it will come together. It is done for first 4 or 5 sutures, and then again we start doing continuous suture or end-to-end anastomosis. Now choosing the right conduit. Now you found the vessel injury. Most of the times there is gap between the vessels. When there is severe trauma, there will be a gap. The gap is because of the debridement of the necrotic blood vessel. So in that case, we need to put the graft. The graft can be autologous graft or artificial graft. Autologous graft will be our great saphenous vein because most of the time it matches the lumen right. And options of the artificial graft are PTFE graft or Dacron graft. After suturing, what post-operative complications we should suspect? Most of the time, early thrombosis is the most, early thrombosis or hemorrhage. These are the most dreaded complications because we want our anastomosis to work. If thrombosis happens, it means our anastomosis fail, our surgeries fail. If the hemorrhage happens, then that hemorrhage may cause life of the patient, and hemorrhage will form a hematoma, and again it will compress the blood vessel and it will cause thrombosis. So anyways, these two things will fail your surgery. So we have to be very vigilant about early thrombosis or hemorrhage. Other thing is graft infection. When we use graft, then it is graft infection. We have to remove the graft and we should see for another autologous graft. Compartment syndrome is the reperfusion injury is another concept which is very important. Usually it is neglected. Reperfusion injury is like we are suspecting the injury has happened around 4 or 5 hours back. Now we are reperfusing that limb. So till now there are factors which are released because of the tissue necrosis which starts, and then we start perfusing that wound. So that necrotic growth factor, factors which come after the tissue necrosis, it will be circulated in the body with that blood flow, and it will cause reperfusion injury. Reperfusion injury can lead to the compartment syndrome, or for that we need to do fasciotomies also. So we have to check after doing surgery, we have to check how our blood vessel is going on, whether it is thrombose, whether it is doing hemorrhage or like. So these are the post-operative complications. Usually after vascular repair, we start heparin or we give stat heparin during surgery also, and after that we use coagulation prophylaxis like injection Clexane, which is low molecular weight heparin, so that our anastomosis remains patent and flow is good. We have to keep blood pressure also adequate so that the flow in the vessel, newly formed vessel, will be good. If we keep it very low, then we have a stagnant blood flow and we may end up in thrombosis of the vessels. Right. So we are done with the theory part, and we will go for the workshop, like actual anastomosis of the vessels. हो झोपलेलं आहे जरा. अजून एक 2 आर्टरी आहे ना मला आर्टरी त्यांना दाखवतो ते क्लॅम्प कसं पकडायचं असतं काय असतं. चला. Now you can consider that this is the cut ends. We have debrided this much part which was necrotic part, and now we got the fresh ends of the blood vessels here. So there will be vascular clamps. We don't have clamps here. Like the clamps will be like this. We have to put a clamp on one side, another clamp on another side of the vessel, and we will bring them together. After bringing them together, now consider that we have applied the clamp and we have got two vessels, two vessel lumens facing each other, right? There is another method which I do for intermittent suturing. We call it as a 3-point fixation first. In that, we will apply. So we will see the intermittent suturing first. One suture will be taken on this side. This is 3-point fixation method. Don't do over tightening of the knot. It should be easily, because the suture you are going to use will be very small. It will frequently get cut if you make it a tight knot, and we don't want to injure the vessel lumen, vessel wall. Now we took the first suture. After that we will take around here, another suture around here. धरत नाही बरोबर. Now we are done with the two sutures. So the clamp will be there which will hold our vessels like this, right? We will twist that band, the clamp, twist that clamp 180 degree, and we will see the posterior wall. So these two sutures will act as anchoring sutures, and then we will flip the clamp. Cut kara. Now we can say we have flipped the clamp and we got the posterior wall, right? And we will give one suture in the center. It will be a thorough full thickness suturing, right? You can imagine a circle where we are putting knots at 60, 60, 60. Like if we divide our clock into 3 parts. So these 3 points will fix that whole circle. And in between these two sutures, usually for smaller vessels like radial artery, ulnar artery, for those arteries usually 6 sutures are sufficient. So after taking these 3 sutures, one suture in between those sutures will be enough. We don't want to put too many sutures. Too much of extra foreign material will cause thrombosis. As less as possible knotting is better. one between these two. Try to keep one end of the suture longer when you cut the suture. Like one suture will be this much and another suture end will be this much. It will be useful when you try to maneuver the vessel. Always holding that vessel will cause damage to the vessel wall. So we will hold the suture and maneuver the vessel. Now we are done with the posterior wall. We will then again flip it back to the anterior wall. And usually one suture is enough. Here the vessel is larger, so I will put two sutures. So we are done with the intermittent suturing of the vascular lumen, right? So this is intermittent suturing. Now we do continuous type. तिथे ठेवू नाही दिसते हां. While doing intermittent type, there are two methods. Few people do. They will take one suture over here, one knot over here. Leave the needle over there, then flip the vessel. They will take another suture, start from the opposite end, now we are on the posterior wall. Continuous suturing is never like 360-degree continuous. There will be one break in the suturing. फॉलो करायला लगा. Now you can see how fast we are doing with the continuous suturing. So the time taken by the continuous suturing is very less. But the drawback is we cannot reopen one of the suture and see whether thrombus is there, why the blood flow is not good, or so initial days of your suturing or initial days of your work, you should do intermittent act. Then when you come to the opposite point, you tie the suture to the previous one. दोन्ही कट करा. नहीं. Now after this posterior wall, we will flick the vessel back. Take the first suture, which was left. And start anterior wall from there. पकड़ा वाला पट के तो ऐसा. This is end-to-end intermittent, this is end-to-end continuous. Most of the times I do is continuous posterior wall and anterior wall intermittent. So we get benefit of the both. Time is less and we can open that vessel anastomosis from the anterior side. Third is, now I will show you spatulation. What is spatulation? If we see one vessel is like this, the lumen छोटा lumen एक कहीं नहीं. If lumen are not matching, then we do spatulation. So we can see the total circumferential area is increased by doing spatulation. So if the vessel is smaller and the another end is larger, we can do spatulation and we can do anastomosis like this. The standard spatulation is always helpful to avoid the constriction band. There is another end to side. Now we want to do end to side anastomosis over here. So first we have to do arteriotomy. And we got the spatulated vessel. Most important thing while doing the anastomosis of the vessel is try to remove the adventitia up to a certain distance, like 2-3 millimeter, so that adventitia should not come in between the anastomosis of your intimal anastomosis. So joining intima to intima is very important. If something comes between the two intima, most of the time it is adventitia, then it is very, well, the anastomosis won't work if adventitia comes in between. So we, after totally denuding the vessel, that keep that vessel over here. So this will be your final way. First we will take this suture. Now the vessel is fixed to this vessel. Both vessels are fixed to each other. Now if it is possible to flip this vessel, then we will flip to the total assembly, we will flip and we will start doing a posterior wall. But most of the time it is not easily possible to flip these vessels in such a scenario. Then we will start from here only, we will pass the suture back and we will start repairing posterior wall from here on, like this. So it is quite difficult. All the layers.
All layers. If you do not involve all the layers, probably you will have a pseudo aneurysm which is small. And another very important aspect is always the edges have to evolve. So whenever anastomosis is done, the edges have to evolve. Can't have any inverted edge because that will lead to bleeding from that area.
So this is the posterior wall. We are done with the continuous suturing of the posterior wall, and then we will do intermittent suturing for the anterior wall, so that it will be easier if we want to open that anastomosis, so you can open.
Just when you finish the continuous
suturing,
show them the Aberdeen's move.
अच्छा मी केली जस्ट अजून आता कट केली आता जस्ट अजून इथं पुढे करतो.
So in vascular anastomosis, usually the proline knot which is at the end of the suturing is always an Aberdeen's knot. Aberdeen's knot is a secure knot which will not be opened up.
आता मी anterior पण continuous करतो मी त्याच्यासाठी.
So otherwise you would have done anterior layer
इंटरमिटंटली आता ते दाखवण्यासाठी फक्त मग. One more thing, before completing the whole anastomosis, remove the clamps, let that blood flow from the anastomosis, let the blood come out from this hole, so that the whatever thrombus debris are there, they will go off and we will form a continuous flow of the blood. फक्त ॲबर्डन घेणं 8-0 मध्ये सर खूप टफ आहे, म्हणजे त्याला खूप प्रॅक्टिस लागते, त्याच्यानंतर ॲबर्डन येईल तेवढं तुटून जाईल असं आहे. हां ॲबर्डन्स तुम्हाला मोठ्या सुचरमध्ये एवढं काही नाही.
Aberdeen knot is a specific knot wherein you form a loop like the previous loop and slide the
व्हेरी सिक्युअर. So this is end to side, end to end continuous, end to end intermittent, and end to side. These are mostly used. Graft, suturing a graft is similar like end to end only. There will be two anastomosis instead of one anastomosis. ठीक है सर, शुरू करो, स्टार्ट. ऐका ना, माझा फोटो द्या ना मला एक काढून. मी असं करतो, माझ्या फोनमध्ये फोटो माझ्या फोनमध्ये एक काढा. एक तिथून काढा, मी शिकवत असलेलं थोडं क्लीन करून काढा. नॉर्मल फोटो काढा, म्हणजे फक्त मी कट करत असल्याचं. तिथून खाली येईल, इथंच येईल. कॅमेरा क्लीन करून काढा. छान. उभा. वर ठीक. कसं करा. बस. ठीक.